Good day, people. We're continuing to talk about assessment here. So as we spoke about in the first video in the assessment series, we need our clear-cut algorithm, and that macro identifies micro. So we talked about that in the intro there, and we demonstrated that macro or large motions identify smaller problems. So we can go from the large frame to the medium frame to the small frame if we start from the large frame. Now, what we want to talk about here and what we're going to demonstrate here is within assessment, ways that I'll actually go about it. So we have two overarching ways, is patient active and patient passive. Now, patient active does a few things for us. It provides us with some understanding of safety. So if the patient can make a movement comfortably in one direction, maybe not in the other, they go farther to the left than they do to the right, then I have information as to what the patient is okay doing on their own. I get some safety information because I know how far they're willing to go in one direction or another, and that I shouldn't challenge that in an overly aggressive fashion beyond what they show that they can do, or at least I should approach it very smoothly and easily. Otherwise I could cause spasm and I could cause injury. So I get some safety information there. I also get a very, very generalized, non-specific motor nerve test. So if a patient can move their hand in this fashion, right, but I ask them to do it on the other hand, and they can only do this, and they can't come back, or if there's any discrepancy, they can't actually actively perform motion, then I have two possible thoughts. The motor nerve may not be working appropriately, or there may be a rupture to a tissue, be it a tendon, muscle. There'd be lots of other signs if it was an injury to a soft tissue versus a motor nerve issue. And it's very rare that I'm going to see that in common clinical practice, but there's the possibility that I can have a greater understanding that there could be a motor nerve issue if the patient can't make the movement. So that's my patient active. Now, patient passive, once I've already done my patient active, allows me to take a finer look at things, to more finely identify things, get them a little bit closer to possibly to past rather their physiological barrier. So I can identify the physiological barrier, how far they're willing to move themselves, and then in a passive sense, I can see if they may have some movement beyond that, or if there's a way that I can approach it. So what we'll do now is we'll move on from this general description and actually display this concept with the patient. We've already spoken about the general concept of assessment, and that patient active assessment allows us to get an understanding of possible issues with motor nerves if they can't make a motion, possible issues with tissue, so if a tissue is torn, ripped, strained, what have you. We can also get a general concept of how far a patient is actively willing to move themselves. So we get motor nerve tests very, very broadly, not specific motor nerves, but very, very broadly. We get to identify if a tissue happens to possibly be injured, so the possibility of injury to a tissue, and we can also see how far the patient is willing to move themselves. So just as a very, very general example, so you can see what this might look like, what we're going to do is we're just going to have you raise your arm straight to the ceiling. Okay? That's patient active. We see how far the patient can go, if there's any quirks of movement, if there's any part of the arm that doesn't move, bring the arm down. Okay, so the arm is gone essentially through full flexion. He's able to keep it straight. There's no issues with motor nerves. There's no issues with tissues. He can move it very freely, just as comparative. Other arm straight to the ceiling. Okay. And then this arm doesn't stay as straight. This arm stays more bent. So we just get a real-time example that we can see some difference. So in comparing side to side, we see some difference with this arm, and let it down. So the patient is actively able to move through a fully functional range. However, there's a difference between the right arm and the left arm. The left arm shows a little bit more dysfunction. But what do we really get out of that? We just get a concept, an idea of where to look farther. And we don't know for sure what is going on, what is not going on. We don't know if there's something going on in the pelvis, the legs, the shoulders. But what we do see with gross motion is that the left arm displays more motion dysfunction than the right arm. So now that we've examined patient active, we're going to look at patient passive. So just to look at the example that we utilized previously with the patient raising his arm straight to the ceiling. So you're going to raise your right arm straight to the ceiling the best you can. Okay? Now the right arm looks reasonably good. There is some bend in the elbow, but that's not unheard of. Let the arm down. When we compare that to the left arm, it may not be perfectly visible, but but this arm doesn't straighten out as much, doesn't come up as high. Okay, so that's patient active. It gives us an idea of safety, so how far the patient can comfortably move themselves, is willing to move themselves. It gives us a general indication if there was a motor nerve problem. So if, for whatever reason, I asked my patient to bend their elbow, to flex their elbow, and the result was essentially this, then I would at least have the opportunity to assume that there could be a tear in the tissue, or there could be a motor nerve issue. I don't know which one I'd have to further test. But now we talk about patient passive testing. So it's when I move the patient. I want to do patient active testing first to give me an indication of safety. So how far the patient can comfortably move themselves. So within this example, this is for visualization. This is not the only way to do any of this. There are many things that can be done. What I'm going to do is I want to mimic the test that we showed you when the patient actively moved himself versus when I move the patient. So I can take his arm and I can take him through the same arc. Okay? And I can passively, when I pull on this, his arm straightens more. So I'm not as concerned with the tissues that would keep the elbow in flexion, at least on the right arm. So what I saw when the patient actively moved himself, with the fact that his elbow wouldn't straighten out all the way, it's not as much of a concern to me because it will straighten passively. I would still like to investigate it, but it's not as much of a concern. Now when I go ahead and come over here and look at the patient's left arm, I'm looking for a difference right versus left. So I saw the right arm moving better in active. I'm looking to see if the left arm still passively does not move as freely or as cleanly as the right arm. And I feel much more tension. The elbow will straighten a little bit more than he's actively able to do himself, but not all the way. But I have to force it, and the arm doesn't come up as easily. It's not visible through the video, but there is more tension when I lift the left arm. Is there the possibility that I lifted it differently? There is that possibility, but there's also a consistency between the patient active and patient passive tests, where the left arm, very globally, very generally, does not move as well as the left arm. So what we're trying to describe here and display is that we would go patient active first for safety reasons, patient passive second, for confirmation of any general findings that I may have in passive. Right? Now I could repeat this process on any level, essentially, in any area of the body, and I can compare side to side. But what we're trying to do is just get across the concept of patient active versus patient passive. So just to see it again for visualization purposes, that lifts quite easily. Okay? Arm straightens out fairly well. Just very general. Is this a specific name test? Not absolutely. It's just to describe, or display rather, the differences. And this shoulder doesn't come up as well, has a harder time coming backwards. Now I've been doing this for quite a while, so the manner in which I'm going to pick these things up is fairly quick. It's not intuitive. I've practiced this a lot, so I pick up on things in a different fashion, or earlier than maybe others will, that are newer to it. It doesn't mean anybody's special, it just means that you've gone through the pattern more. And so when I notice something that isn't equal side to side, I can test it very quickly. So as a demonstration of that, just to expand on the concept, pull up, arm comes back freely, shoulder moves quite freely, no problems. As I lift this left arm up, and I don't know if this will visualize properly, but as I lift it up, there's tension, the arm stays forward closer to the camera. I'm going to pull it back, and there's tension on it. I pick those things up quite quickly, not because there's any magic to it, but because I've moved many, many bodies for a very long time. And over time, with practice and repetition, those things will become noticeable to you. It's not magic, there's no special palpation, it's just something you learn over time.